we're going to be talking about IV therapy. Prior to coming on campus, please refer to your IV therapy objectives, as well as review of the videos that are posted on Blackboard under the Skills Exam/SPE information. This will be very helpful to you and beneficial so that when you are on campus and we are reviewing the flushing, administering a primary IV, administering a piggyback, as well as administration of tandem. We're talking about IV therapy and the methods of delivery. The one we see on the left is the peripheral lines. Peripheral lines are shorter catheters, and they're usually placed in the distal veins in the arm, as opposed to the picture on the right, which shows a central venous catheter. These catheters are longer length catheters, and they're usually placed in the subclavian or jugular vein or peripheral with a PICC line. And again, central lines we are not going to be talking about in today's lab. That is something that will be covered in length in a whole lab on itself. So the focus for this lab will be on peripheral lines only. Prior to insertion of IV catheters, we need to think about a couple things before we put these catheters in. We have to first think about the condition of the vein, the type of fluid or medication that will be infused, the duration of therapy, whether the patient is right or left-handed, the setting that it will be taken place in, whether it's in an outside ambulatory surgery center or whether it's something for more long-term use in a hospital, and the history and condition of the patient. We usually select a vein that is easily palpated, feels soft and full, is naturally splinted by bone, and is large enough to allow adequate circulation around that catheter. When we're looking for our sites, we use the distal veins in the arm first. So we always start low, okay, and then proceed upward. So we're going to use the distal veins in the arm first, followed by the sites proximal to the previous site. The median cubital, median basilic, and median cephalic veins are good for blood draws, but are difficult for continuous IV infusion due to the bending of the arm by the client. These are the patients that we see a lot of times in the hospital where, we constantly hear their IV pump going off because they're bending their arm. We ask them to straighten their arm, and then the fluid continues. The best IVs to use for patients, the best sites I should say to use for IVs in patients, is a cephalic vein is better due to natural splinting of the bones of the forearm, and the dorsal metacarpal vein in the hand, again because of the natural splinting as well. Infants, common IV sites would be the scalp veins, and you could see here the posterior auricular vein, the superficial temporal vein, and the frontal vein. Sites to be avoided when possible for peripheral IVs that nurses need to be aware of and look for is patients that have dialysis access or arterial venous fistulas in their arm. Again, we would never want to put an IV anywhere near that. Arms affected by hemiplegia. Again, paralysis from stroke that patients may have had. The same side as a patient that has had a mastectomy. Sites near an infection. Sites below infiltration, extravasation, phlebitis, or thrombosis. And again, this is why we start low and continue higher. Legs, except for in infants, we may use the foot vein, and in surgically compromised or an injured extremity. So let's think about it in the clinical setting. Have you seen anything that might indicate that one arm is not able to be used, again, for peripheral IVs, for blood pressures, or for central lines? And I know that in the hospitals I've been in, I sometimes see that they have limb alert bracelets on, or they may have a sign over the bed saying do not use left or right arm. And again, most times it's for a reason like this. But we as nurses need to be aware, looking at the history, looking at what's going on with the patient. Things can change as the patient is there. So the patient may, not have had an infiltration earlier, but you notice one now. So again, we need to be aware of that when we're looking at different sites to insert these peripheral IVs. An angiocatheter is an over-the-needle catheter where once the vein is assessed, the needle is removed and only the catheter remains. Angiocatheters come in different colors and different sizes. This is referred to as the gauge. Different gauges are used depending on what fluids need to be delivered. The larger the gauge, the smaller the needle. Most commonly used is the 20 to 22 gauge catheter. For more rapid infusions and viscous solutions, you would use a 16 to 18 gauge needle. When we look at midline peripheral catheters, these are different than our peripheral venous access devices, our angiocatheters, in the fact that they're longer in length. They're about 6 inches long. But these two are flexible catheters. They're usually inserted into the antecubital or fossa and then advanced into the larger vessels of the upper arm for greater hemodilation. It's about 6 inches long, and it can remain in use for a longer period of time. The book does state that it can stay in for about 1 to 4 weeks, but the median is about 7 days. We are seeing these both used in St. Peter's and Albany Medical Center. So when you're out in the clinical setting, the most important thing to do is to refer to what your protocols are for the care of these peripheral venous access devices, depending on whether you have just a regular angiocatheter or a midline peripheral catheter. Blunt plastic cannulas are used to attach IV tubing to peripheral venous access devices. These are self-sealing ports that can be accessed with syringe tip or the end of IV tubing. These self-sealing ports must always be cleaned with alcohol before using. How long do we clean with alcohol? We should clean for a full 30 seconds. And again, you really want to scrub very hard. A lot of times people will scrub around the whole thing. Really on the top, hard friction back and forth to really remove any microorganisms that may be on that port before you're inserting anything into it. So when we look at this slide, we could see in the upper left corner, we have them actually going to insert the IV catheter into a patient. And if you look closely, you could see the white plastic catheter with the pink attached to it that has the needle underneath it. So after that is inserted into the vein, and the next picture below it, you could see where you hold that catheter in place and you remove the needle itself. So the needle does not stay in the patient, but only the catheter. And then below that, you could see where the catheter is just there with nothing attached to it. This is where we attach the IV tubing, and the IV tubing will have that blunt end on the end, that needleless system there, okay, that blunt plastic catheter for us to be able to access. And then once that is all attached, we will put a dressing on this. We usually place a Tegaderm dressing on this, and then we're able to attach this to our IV. Flushing the IV site is done with 0.9% sodium chloride or normal saline. This comes in a pre-filled syringe. So why is it that we flush this IV site? Again, we want to make sure we want to assess the IV site for use. We want to make sure we maintain patency when not in use. And we want to assess if this site is patent. So in the clinical setting, when you guys do your head-to-toe assessment and we notice that a patient has an IV, again, we're going to look to see, are fluids running in that IV? Does the site look okay? And if everything's running okay, we don't necessarily need to flush it. But say that the fluid was running very sluggishly or the pump was going off, we may at that time flush the IV to assess to make sure that it is patent, okay, that there is no problem with that IV. If patients don't have IV fluids going, we would want to flush that IV site at least once a shift or per agency policy. And again, if we're given medication through that line, we want to flush before to check for patency, give the medication, and then flush afterwards to keep that IV site patent. When we're looking at flushes in the clinical setting, the normal saline usually comes in pre-filled flush syringes, and they're usually 3, 5, and 10 milliliter syringes. What we usually see in the clinical setting for use is the 3 to 5 mLs is what we're flushing these peripheral IV sites with. Again, it's going to depend on what hospital you're in and what their protocol is. We will practice in the lab flushing an IV so that you can become comfortable with that. It's important to remember that clotting can occur in these IV lines if they are not flushed and clamped off due to the backup of blood flow. This can be prevented by not allowing our IV solution bags to run dry, by taping the tubing to prevent kinking and maintain patency, to make sure that we're maintaining an adequate flow rate, and flushing the line after intermittent medication or other solutions have been administered. If a clot occurs, the line should be disconnected. Do not ever force a flush if resistance is met. Electrolyte lecture, you will discuss why certain fluids will be used depending on the patient's condition. You must know the abbreviations for each of these solutions. So the first one we see is lactated ringers. This is referred to as LR. 0.9% sodium chloride is NS. 0.45% sodium chloride is half NS, or half normal saline. 5% dextrose and lactated ringer, D5LR. 5% dextrose and 0.20% sodium chloride, D5 and a quarter of normal saline. 5% dextrose and 0.33% sodium chloride, D5, 1/3 normal saline. 5% dextrose and 0.45% sodium chloride is D5, half normal saline. Now take a look at the following IV bags and see if you can name the abbreviation for each of these solutions. When we look at the assessment and management of peripheral IV sites, our assessment is ongoing, and we know that things can change at any moment when IV solution is infusing. The first complication that we may see is a hematoma. To assess for a hematoma, we may see some ecchymosis, a localized mass, or some discomfort at that site. The cause of this can be from a nick in the vein during insertion or when seeing an IV without holding pressure. It's important to note that for a hematoma, this is completely preventative, and this can be done by using a gentle technique when inserting the IV and holding pressure when discontinuing an IV. Another thing we may see is a phlebitis. So if we look at the pictures here, the picture all the way to the right with the blue background would be phlebitis. With this, we will see redness, pain, and warmth at the site. We may see some local swelling, a sluggish infusion rate, and maybe a palpable cord along that vein. Causes of this is from mechanical irritation, infusion of solutions that are irritating to the vessel, trauma to that vessel, movement of the line, compression on the line, and certain solutions like potassium chloride, antibiotics, may also cause phlebitis. So how do we treat these patients with phlebitis? Well, we're going to discontinue that IV infusion. We're going to restart in a new location, and we're going to apply a warm compress. The next thing we see is assess for infiltration. With infiltration, we see that's the picture on the bottom of the slides. We can see that we have swelling, tenderness, pallor, hardness, coolness at the site, and you may see a slowed or stopped infusion. Causes of infiltration is due to the catheter becoming dislodged. So what do we need to do for this? We need to stop the infusion immediately. We need to restart the IV infusion in a different vein, higher in the extremity. And what we'll do is elevate that affected arm on a pillow to promote absorption of that excess fluid. The next thing we see is extravasation. With extravasation, this is seepage of a vesicant substance into the tissue. This causes blisters and subsequent tissue sloughing and necrosis. So what we will see with this, we'll see pain, burning and swelling, blanching, coolness of the surrounding skin. Again, causes of this is because the IV catheter has become dislodged. So how do we treat this? It's going to depend on the severity of the infiltration, but we're going to stop that IV infusion. With some medications, it may require administration of an antidote, and we're going to apply a cool compress and elevate that extremity. IV site infection prevention. The first thing we're going to do is hand hygiene before every contact with any part of the infusion system or the patient. After we do our hand hygiene, we're going to don gloves and we're going to assess that site. Again, looking for what we described in the slide previous. We want to make sure that we alcohol all ports before assessing them. And we talked about really scrubbing that hub. And what we use for our peripheral IVs is the alcohol, and we should scrub for a good 30 seconds. Sterile tubing and bags. We want to keep both ends of tubing sterile. So we need to use strict aseptic technique. Solutions are good for only 24 hours. And when we think about tubing, how often do we need to change this tubing? Again, it's going to depend on the agency policy to where you're working, but we're generally seeing it's about 72 to 96 hours for continuous IV fluid and 24 hours for intermittent infusions. Never leave ends of IV tubing uncovered. So you'll see in the clinical setting sometimes that people will disconnect an IV. If they disconnect an IV for any reason and do not put a sterile cap on it, we cannot use that IV tubing. So if we go in and we see that this IV tubing is left uncovered by another nurse, we cannot use it. We need to do a whole new setup for this patient. Keep IV site dressing dry and secure. Change the dressing per agency policy if loose or wet, and we should make sure that that IV site is anchored. What I mean by anchored is that it's secured, it's taped down. This is going to help with that movement of that catheter that can cause a phlebitis. IV site change per agency policy. Again, usually IVs can remain in if there's no problems with them, or some policies will have you change out an IV every 72 to 96 hours. So it's important to remember when we're looking at these IV sites that we want to inspect, again, our solutions. Look to make sure that they're not cloudy, that there's no leaks in the container. Make sure that that IV site cannula is firmly anchored, again, to prevent any movement, and inspect that site and dressing. And we should be doing this again with our head to toe assessment when we go in there. And then again, every time we're looking to give anything through that IV site. So again, at least every shift, but then again, with any use of that IV, we should also be assessing it at that time as well. When we look at our intravenous tubing, we see that there's different types that we can choose. The first thing we see is primary. This is our long tubing. It's for administration of continuous IV fluids. When we look at secondary, this is more of our short tubing. And this is for administration of piggyback, IV meds that are connected to that primary tubing. When we look at our tubing packs, we will see that they may say macro drip. Macro drip will come in 10, 15, and 20 drips per milliliter. And we'll talk about this a little bit more in the actual lab when we're talking about administration of medication using macro drips and how to figure that out. Micro drips is 60 drips per milliliter, and this is used for gravity flow of IVs that deliver small amounts, so about just 25 mLs an hour. A volume-controlled tubing, or a burette or saluette, has a chamber on the tubing that holds only about 150 to 200 mLs, and this protects clients from accidental infusion of 500 to 1,000 milliliter bag. This is used in pediatrics and if concern of fluid overload for a patient. Tubing for administration of blood, we will see that comes with a filter on it. And again, this is to filter out any particles within that blood before the blood reaches the patient. So a different type of tubing that we would use with just administering IV fluids. The important things to remember is that with these tubings, when we choose it, we need to be sure to purge all air from the tubing before use. When we look at regulating the IV flow rates, you can see the first thing we're going to talk about is gravity flow. To do gravity flow, this is done using the roller clamp. This is where we would have to figure out a calculation of how much fluids we wanted to administer based on the tubing that we have and whether it was 10, 15, or 20 drops per milliliter. So what we would do is when we attach this to the patient, we would actually regulate the flow using that roller clamp. The electronic infusion devices, again, we would use with primary tubing, and this would be where we would set the pumps in milliliters per hour as opposed to the gravity flow, which is drips per minute. So when we look at gravity flow, again, when we talk about our calculations, gravity flow will be in drips per minute. And when we look at our electronic infusion devices, we will see this in milliliters per hour. It is important for you to know how to do both because, again, sometimes in the clinical setting, pumps are not always available, so we will use the gravity flow rate, but most times we will have the capability of using the electronic infusion devices in the clinical setting. When we look at IV mini bags, we can do this via the piggyback method. So using the piggyback method, we could see that we would first, if you look at the picture on the right, we have our primary IV infusing. So our primary IV would be our main IV infusing, and this would be with our long tubing, and this would be attached directly to the patient down at the bottom. So to administer a piggyback, we would spike the mini bag with short secondary tubing and attach it to the port closest to the IV mini bag. So if you look over at that secondary piggyback, you can see the tubing is much shorter and it's attached to the port closest to that primary bag. We then want to hang the primary IV bag lower than the IV mini bag. Again, you have to think about it with gravity. The one that's going to drip is always going to be the highest one. Then to regulate this, we're going to open the roller clamp of the secondary and regulate the drip rate using the roller clamp on the primary. And we will go over this very in detail in the clinical setting and also show you the back flush method as well. I would suggest that you look at the videos that we have posted on Blackboard to help you with this. One thing to remember though, when you're mixing any type of IV fluid using this piggyback method, we want to make sure we look at compatibility. So compatibility means that are these fluids able to be mixed together? And you need to make sure that IVs are compatible before we administer them in the same line, because if not, we can get crystallization in that line and problems with that medication upon administration if we do not check compatibility. When we look at the tandem method, you can see that we have two IVs hanging, and they look very similar. Again, they're both using primary tubing, and they're both going to run on their own. So again, Minibag is attached to the line of the primary IV at the lower secondary port, so down the one just above where it goes into the patient. This is going to permit medications to be administered simultaneously with the primary solution. As opposed to with the piggyback, what we're doing when we're doing the piggyback method is we're actually stopping that primary medication and administering the piggyback, and then it's going back to the primary. With the tandem, they're both being administered simultaneously, okay, at the same time. We use this with medications that may be irritant to veins, so additional fluid is given at the same time, or if just they need both medications because the patient may be dehydrated or require that fluid and only have one IV, and we really don't want to stop that main IV, would be a reason for using the tandem method. If we needed to administer an IV mini bag with no IV infusing, again, we would need to flush that intermittent infusion device with, we said, generally 3 to 5 mLs of normal saline prior to administering this IV mini bag. If we didn't have a primary going, we could run this IV mini bag as a primary using the long tubing. Okay, we need to make sure we purge all the air, and we attach the tubing directly to the patient. And again, we would regulate that drip rate using the roller clamp. I will tell you that sometimes in the clinical setting with IV mini bags, we will see them attached to just normal saline. Again, the rationale for the IV mini bag will be run as a piggyback. And the rationale for this is that we want to make sure that they receive all of the IV mini bag. A lot of times, if we use just primary tubing, there is a lot of medication that's still left in that tubing. Whereas if we run it as a piggyback, we can run the whole antibiotic through with a flush. And again, we will explain this fully when you are on campus in the laboratory, but please ask if you don't have an understanding of this.